Well, welcome everyone. My name is Ellie Thiel. I'm a professor of laboratory medicine and pathology here at Mayo Clinic. Thank you so much for joining today's Future Directions of Laboratory Medicine webinar. It is my absolute pleasure to introduce today's speaker, Dr. Divyanshu Dubey. Dr. Dubey is a professor of neurology and co-director of the Neuroimmunology Laboratory, and he'll be presenting on the topic of autoimmune peripheral neuropathy. And so with that, Dr. Dubey, the floor is yours. Thank you.
Thank you, Dr. Thiel. Thank you for introducing me, and thank you for the opportunity to talk about an area which I'm very passionate about. As we go through this talk, we'll focus on autoimmune neuropathies, which form a subset of all peripheral neuropathies, but a very important subset, a subset which often can be treated and patients can notice improvement in their sort of neuropathy symptoms and the morbidity caused by the neuropathy. Our lab specializes in offering tests to diagnose these autoimmune neuropathies, which are not only can help patients with answers in terms of what is causing their neuropathy, but also can guide treatment. And I'll try to touch on that during this talk. These are some of my disclosures. We'll talk about some of the antibodies that we've discovered in our lab. I'm not going to go too deep into clinical trials or sort of additional immunotherapy focused discussions. Again, as I said, the objectives are going to be reviewing clinical and electrodiagnostic features of seropositive autoimmune neuropathies, also reviewing the clinical specificities of neural autoantibodies and how they associate with autoimmune neuropathies, giving you, also, in addition to the clinical perspective, that's the perspective I have from seeing patients in the peripheral nerve clinic, I would also like to share some of the lab perspective, but also in a way that is sort of usable or relatable for clinicians worldwide. How should we interpret these tests? When should we be concerned that the test results are not necessarily answering the question we are asking or potentially misleading us? All those are very relevant, very important as neurologists seeing patients with neuropathy suspected to have autoimmune etiology. As I said, neuropathy is very common. It's about nearly 3% of people walking around have neuropathy. The frequency of neuropathy keeps going up as we get older. In sort of beyond 60, that percentage goes even higher, close to sort of 5% and 10% as time goes on. But the important thing to remember is the neuropathy has wide variety of causes. And autoimmune or immune-mediated neuropathy is a small subset of that, but as I said, a very important subset of that, which can be present in up to 10% of patients who have neuropathy presentations. And figuring out not just whether it is autoimmune, but what kind of disorder, what kind of autoimmune disorder it is crucial. And we are hoping some of the tests we are offering in the lab can help us in this process. So this is our approach to antibody testing, and this is the approach we kind of we talk about or we could recommend, where the initial step of neuropathy evaluation is very focused on clinical assessment, neurological examination, history taking, also the EMG. So we can characterize the neuropathy based on their phenotypes, and subsequently we think about what testing should be done or what investigations should be considered for a particular patient presenting with neuropathy. By using these steps, by doing these investigations upfront and then narrowing down or thinking about the panels, not only serves us well in terms of making sure all relevant antibodies are covered by the panels we are sort of sending for, but also increases the pretest probability and reduces the false positivity because no matter how perfect we make the panel, oftentimes the specificity is not 100%. Even a panel which is 99% specific can generate some false positive results if people are sending it in all types of neuropathies. And I'll go through each of these phenotypes or some of these phenotypes as describing individual cases that I've seen in clinic or in the hospital to give you a better idea and then think the certain antibodies associated with them. But again, keep that in mind, the different phenotypes of neuropathies, and then dividing the phenotypes based on axonal neuropathy or demyelinating neuropathy, that is then wiring inside the copper wire, if you think of your nerves to be with copper wires, or the insulation of the copper wire where the damage is happening. can guide you to make sure that you're sending appropriate testing for patients. So this is one of my patients I'd seen in the hospital, 66-year lady diagnosed of metastatic Merkel cell cancer and started on immune checkpoint inhibitors of pembrolizumab. This is a clinical scenario that we are starting to see more and more in our practice, as well as practice all across the US, in terms of cancer patients receiving cancer immunotherapies and subsequently developing some side effects. And one of the side effects is neuropathy, like this patient suffered. So within a week of the first infusions, she started experiencing numbness involving her hands. Along with the numbness, had some dizziness or sort of vertiginous sensation as well, started developing significant gait instability, suggesting it's not just the peripheral involvement, they might be kind of coexisting central involvement as well. But the MRI workup, which was done to look for cerebellar pathology, brainstem pathology, all came back normal. The symptoms continued to progress, developed gastroparesis or autonomic nervous system involvement, and the EMG nerve conduction studies, which were done, showed evidence of sensory ganglionopathy, which kind of explains some of the ataxic presentation, suggesting this could be sensory ataxia contributing to gait instability, but also explains the loss of sensation in the hands, presenting in an asymmetric fashion, with hand involvement, one side getting worse and then subsequently jumping onto the other side. This was enough for us to suspect this is an autoimmune process. Patient was started on immunotherapy or immunosuppressive medication, but also antibody testing was sent, and antibody testing came back positive for an antibody called as ANA1 or anti-Hu antibody, which is associated with this type of neuropathy or sensory neuropathy or ganglionopathy. This is in some ways similar to the classic anti-Hu cases that we encounter in the setting of neuroendocrine tumors such as small cell lung cancer, also Merkel cell cancer. But the one additional aspect here is this is also triggered by a medication that we gave the patient to treat the cancer. Oftentimes, some of these patients can be much more progressive or faster progressing than some of the classic paraneoplastic cases. Unfortunately, despite aggressive treatment with steroids and with cyclophosphamide, patient had a GI perforation from the gastroparesis. Given the immunosuppressed status, that didn't really help. Went into sepsis. Finally, the family decided to choose palliative care, and the patient passed away. This is one such example of some other cases that I've encountered where the classic paraneoplastic phenotypes unfortunately don't do as well. They tend to be more progressive, more refractory to treatment. In terms of in terms of treatment, we tend to be very aggressive upfront to prevent such situations from happening where the disease has sort of progressed to involve autonomic nervous system or other parts of the nervous system. The important thing I want to take you to take home from this case is certain things or red flags that should make you think about testing for anti-Hu or testing for paraneoplastic antibodies. One of them was the asymmetric onset with the upper extremity involvement, that to one side upper extremity involvement, so not your typical neuropathy with numbness, tingling involving the toes of the feet. Had a progressive course in a relatively rapid fashion. Patient was getting worse day by day or week by week. Had coexisting dysautonomia with involvement of GI system, but also can involve other aspects such as orthostatic intolerance, the cancer history, the immunosuppression, immune checkpoint inhibitor initiation history are all those red flags that should make us think this could be one of those rare autoimmune neuropathies that we need to be very aggressive about in terms of investigations, diagnosis, and as well as treatment. This is an autopsy image from one of review articles on sensory ganglionopathy written by my colleague, Dr. Amato, which showed that these ANA1 or anti-Hu patients with antibodies targeting this protein are usually driven, the disease is driven by cytotoxic T cells, potentially targeting the same ANA1 or anti-Hu protein, causing destruction of the dorsal root ganglia, and then secondarily causing degeneration in the dorsal column as well. We've done sort of extensive work on anti-Hu autoimmunity. Neuropathy seems to be the most common presenting phenotype, especially in older individuals, like this particular patient. And the sensory ganglionopathy is the most common presenting type of neuropathy that we encounter with this antibody. Interestingly, anti-Hu is not just restricted to older individuals. There are few cases of pediatric as well as middle-aged patients where we have seen this antibody as well. In pediatric age group, it tends to be associated with neuroblastoma. It tends to have more CNS presentation, such as limbic encephalitis or opsoclonus myoclonus syndrome. But interestingly, in the middle age, oftentimes we don't find a cancer. But even in these cases, sort of the phenotype resembles the typical older individual with paraneoplastic autoimmunity. The pediatric or the young patients do really well, respond to therapy, get better, but unfortunately, both the middle-aged and older individuals, like our patient, don't do as well. Another classic paraneoplastic antibody is this one. So this is a 69-year-old gentleman who presented to our ER with asymmetric pain involving the lower extremities and numbness, again, in a progressive course. So that there are some things common between these cases. Asymmetry is common. Progressive course, relatively rapid progression is something else which is common. And again, he had a very long history of sort of smoking. You can clearly see there's something abnormal or atypical in this picture. Those are the protuberances in the abdomen. These were sort of hernias from weakness of his abdominal wall occurring, which was secondary, we suspected thoracic radiculopathy. Patient was admitted to the hospital, subsequently underwent EMG workup, which revealed phenotype consistent with axonal polyradiculoneuropathy. A nerve biopsy was performed, which clearly showed this is an inflammatory autoimmune neuropathy with lymphocytic cuffing and infiltration, specifically around the blood vessels. And then, lo and behold, the antibody results came back positive for an antibody called as CRIMP5. This is another antibody that was discovered at Mayo Clinic around the same time. It was also discovered by a group in France. Subsequently, we've characterized the phenotypic presentations with CRIM5, and the most common presentation seems to be neuropathy. In this particular patient, once we found CRIM5, patient underwent a PET scan. PET scan showed hypermetabolic paraaortic lymph nodes, which on subsequent biopsy were confirmed to be mixed small cell and non-small cell lung cancer. Uh, Again, as I said, the CRIM5 is another classic paraneoplastic antibody, or what we call nowadays high-risk paraneoplastic antibody, similar to ANA1 or anti-Hu. Again, the phenotype is slightly different. The most common presentation in CRIM5 neuropathies ends up being polyradiculoneuropathy, whereas most of the ANA1s present with sensory ganglionopathy. The rate of dysautonomia seems to be more common in NR1, whereas the presence of neuropathic pain seems to be more common in CRIM5. And both of these antibodies we are starting to see in the setting of immune checkpoint inhibitor use, specifically in patients with neuroendocrine tumors. So small cell lung cancer, Merkel cell cancer, the two cancers I'm specifically talking about. These are the post-ICI neuropathies, which tend to be more refractory to treatment and also tend to be much more aggressive than some of the immune checkpoint inhibitor neuropathies that we have encountered in patients with renal cell cancer, melanoma, etc. Those are the ones where you will encounter Bell's palsy following immune checkpoint inhibitor or GBS-like presentation following ICI, and they tend to do better after stopping the checkpoint inhibitors and potentially starting these patients on steroids. Some of these neuroendocrine complications tend to be much more difficult to treat and often require pulling the trigger on second-line agents such as cyclophosphamide, rituximab, etc. And most of the neuroendocrine associated ICI neuropathies we've encountered are positive for some of these high-risk paraneoplastic antibodies like the ones we talked about, and ANA1 or CRIM5. Moving on to another case. This is a lady who was sent to my clinic for a second or a third opinion for a question of motor neuron disease or ALS. She had history of respiratory failure and this progressive weakness. And again, the important thing here is this is different from the first two cases because the rate of progression was somewhat slower or much slower, again, which made the providers elsewhere think, could this be ALS? She had this history that of episodes where she had difficulty breathing. Subsequently, was on investigation was found that she had vocal cord immobility that was causing these episodes of inability to breathe. also had history of dream enactment behavior where she was acting out her dreams at night, noticed by the family, and then had this progressive asymmetric weakness involving arms and legs, as well as sort of neck weakness leading to head drop. Examination was consistent with what we were sort of noted in the history. There was neck extensor weakness, upper extremity weakness, left greater than right. Again, the asymmetry pattern. And then the lower extremities were also weak, and the reflexes were relatively preserved despite the weakness and atrophy. So again, something pointing towards a diffuse, multifocal, motor-specific process. And that's what the EMG showed. There was sort of evidence of fibrillation, fasciculations in multiple myotomes. So I can't necessarily blame the initial suspicion for diagnosis of ALS. But there was something atypical about this case, which made me think, should we investigate this further? And the atypical things were the bizarre dream enactment behavior. So REM behavioral disorder is not something we typically think about in our ALS patients. And then this history of vocal cord immobility at the beginning of the disease. Vocal cord immobility can be encountered in ALS, but usually it's a later part when we see this. So that's what led to us sort of investigating it further, including antibody evaluation. And antibody testing came back positive for an antibody called as Iglon-5. Um, since this case, we have encountered others as well, nearly half a dozen cases now, which are positive for Iglon-5 antibodies. Most of them present with some of these other atypical presentations along with the ALS-like phenotype. And the reason why it is important for us to suspect or diagnose these conditions is because these can actually, we can stop the disease from progressing. Or in some rare cases, we have seen patients improve with initiation of immunotherapy. This is not just our observation, but others, sort of a group in Europe has also reported Iglon-5 associated motor neuron disease, where some of these patients had bulbar predominant presentation or suspected to have sort of bulbar predominant ALS. But again, remember that all of these cases had those red flags, evidence of REM behavioral disorder, presence of involuntary movements like chorea that like we had found in one case, and then early vocal cord involvement. So I'm not recommending testing Iglon-5 on every ALS patient that you encounter, but what I'm recommending is asking these questions about dream enactment behavior, about vocal cord involvement early on in the disease process, or checking for involuntary movement, which should make you think, could this be Iglon-5 autoimmunity rather than a neurodegenerative process such as motor neuron disease. Another phenotype for motor neuronopathy that we have encountered and published on relatively recently is paraneoplastic flail arm syndrome. This is one of our patients with history of testicular cancer who developed weakness involving predominantly the upper extremities, significant atrophy proximally, some weakness distally, but the weakness was much more profound proximally, as you can see on this video.
Come around the back here.
So more of like a man in a battle-like presentation with significant proximal atrophy. You can see the atrophy at the back. As Dr. Eggers asks the patient to move his hands, you'll see
try to
there's
open
not
your
much
hands
proximal
and lift
strength.
your arms a little bit. Okay. All right. How about making fists? You make fists.
But he's able to move
And then open the
the
hands
fingers
again.
distally.
Good. Okay.
And this is just one
And
patient,
how
but
about
there are some
shrugging the
other
shoulder?
cases like this that we have sort of seen. These are some of the pictures of those other cases that we've encountered, all presenting with proximal weakness, slight asymmetry in presentation, without a lot of sensory deficits. Hence, they were suspected to have bibrachial ALS. And all of these patients were positive for an antibody called as leucine zipper 4, and some of these were also positive for calc-11. Two of these three cases you can see in the pictures had testicular cancer. Since then, we've also encountered patients with ANA1 coexisting with leucine zipper 4, who've been sort of found to be positive and had phenotypes resembling a paraneoplastic flail arm syndrome. In most of these cases, they had some multifocal involvement, sometimes coexisting brainstem involvement, and then the rate of progression was faster than what we typically encounter in bibrachial ALS. So those are other red flags to consider when thinking about or investigating these antibodies. So we were initially talked about a sensory ganglionopathy phenotype, which is an axonal neuropathy. Then we talked about axonal polyradicular neuropathy and TREM5. Then we talked about motor neuronopathy or ALS-like presentation with Eglon5 or some of these paraneoplastic antibodies. And now we're going to briefly move over to some of the demyelinating physiologies that we encounter. This is one such patient who presented to us few years ago, initially was being seen at an outside facility, had onset of bilateral hand numbness, and they suspected could this be carpal tunnel, underwent carpal tunnel release, don't really help the symptoms. But soon after, the disease started progressing, started noticing that his ankles were turning, had some imbalance, along with the neuropathy features, also started developing some autonomic dysfunction, the erectile dysfunction, had some CNS like features with slurred speech, clearly a diffuse multifocal disease. And this is around the time when he came to Mayo Clinic. On examination, he had distal more than proximal weakness, so bilateral foot drop, proximally the thigh's strength was relatively intact. This is different from those other cases because the weakness was relatively symmetric. In addition to weakness, this had also had sensory involvement with sensory ataxia, lack of reflexes, and suggestive of cerebellar tremors, not just pure sensory tremors or sensory ataxia associated tremors. Nerve conduction studies were performed, which showed evidence of slowing, suggestive of demyelination, without temporal dispersion or conduction blocks that we typically encounter or make us think about acquired disease processes such as CIDP. In this particular case, subsequent investigations were sent, and patient came back positive for an antibody called as neurofascin 155. And again, this is not your typical CIDP case. There's some things which are suggestive of a neurofascial autoimmune neuropathy, and those things are this predominance of sensory ataxia or significant sensory ataxia. Some sensory ataxia is something we see in CIDP as well, but the level of proprioceptive loss was pretty marked and is usually very significant in neurofascial cases. The tremor is another clue. Oftentimes, it's not just the tremor in the hands, but you can also sort of hear a voice tremor or some dysarthric speech. That's usually the first thing that makes me think about neurofascial autoimmunity. Many of these patients come to us as for second opinion for refractory CIDP because they've been given IVIG and they're not responding. That's another red flag. This could be neurofascial autoimmune neuropathy. Usually, most of these patients have markedly enlarged, really thickened nerve roots. And then there are other features that we've encountered in these and published on, that is presence of neuropathic pain. That's not something that typical CIDP patient usually complains of. Some dysautonomic features, cranial nerve involvement. Those are other red flags that can make us think about neurofascial autoimmunity. We've not only encountered this in adults, but very recently we published nearly a dozen cases with pediatric onset neurofascial autoimmunity. Unfortunately, many of these patients were not diagnosed for more than a decade, leading to buildup of morbidity. Some of these kids, unfortunately, had developed contractures by the time a neurofascial testing was sent or diagnosed, and then subsequently their treatment was switched to B-cell depleting therapies such as rituximab, leading to either stabilization or improvement in their deficits. Interestingly, the presentation looks very similar to the adult neurofascial cases, just the frequency of sensory ataxia is significantly less common. Again, I think in really young kids, you can imagine that's one of the limitations. How can you really do a very good proprioceptive analysis? But keeping that in mind, phenotypic similarity, even the nerve pathology has similar features with sort of evidence of demyelination without conduction block, with coexisting features of axonal loss. And most of these patients, if started on B-cell depleting therapy, respond very well. Neurofascin is one such antibody that we think is pathogenic, and some of the work done by our colleagues in Europe, including a passive transfer model with chronic infusion of neurofascin IgG4, has demonstrated this sort of the pathogenicity. You can see in this particular mouse model where the one on the left is the control IgG4 mouse, clearly is able to hold up the tail, able to move the hind limbs, whereas actually this is a rat, not a mouse. On the right side with the neurofascin 155 IgG4 infused rat is not only has weakness in the hind limbs, the tail is also limp. This thought process is the chronic infusion of neurofascin IgG4 leads to binding to the neurofascin protein expressed at the level of the paranodes, subsequently inhibiting or limiting the interaction of neurofascin with the contactin Caspar-1 complex, which in turn causes injury, swelling at the level of paranodes, which we have seen in Key's nerve fiber preparation, where there's swelling in that junction. It has also been demonstrated through some EM studies done by our Japanese colleagues. This is the EM of a CIDP patient. You can see the myelin sheath, the axon, there's no space between the two, whereas a EM of a neurofascian autoimmune neuropathy patient, there is not only myelin whirling, but you can see there's development of clear space at the paranode, which you can imagine if there's an antibody going and binding the interaction, preventing the interaction of neurofasciin 155 with contactin, that can in turn lead to swelling and damage in that region. As I talked about this case and this particular disease, I kept mentioning neurofasciin 155 IgG4. That's an important thing to remember, and we'll talk about it more as we go along later on during the sort of the lab focused part of the talk. Testing specifically for IgG4 gives you more clinical specificity for autoimmune neuropathies. In our experience, the patients who are IgG positive but IgG4 negative for neurofasciin 155 often don't have that phenotype. So our current live flow-based assay testing for neurofasciin specifically looks for IgG4. Moving on to another case, it was a 19-year-old gentleman who presented here and saw one of our colleagues presenting with numbness and tingling involving hands and forearm bilaterally. Again, a non-length dependent pattern of disease onset. Subsequently, after the hands were involved, the legs were also starting to get involved with the sensory predominant presentation, developed significant gait instability. On the examination, as you can see down here, this is the Mayo system of numbering on neuropathy impairment score, with 4 being the worst score. Had significant proprioceptive or joint position loss with large fiber involvement with vibration loss as well, and some small fiber involvement too. This is the pattern of sensory loss which we saw in examination. Given this picture, we are all suspecting a large fiber neuropathy with significant sensory ataxia, but subsequent workup, including EMG and the MRI of the spine, was normal. But in this particular case, given the suspicion for autoimmune presentation, young age, rapid progression, antibody testing was sent, which came back positive for contactin Caspar-1 complex antibody. So in our clinical testing, not only we test for contactin by itself, we also do a CBA where we have co-expression of contactin and Caspar-1 and look for binding at the complex. And this patient was positive just for the complex antibodies. In this particular patient, if you think electrophysiologically, EMG is normal, MRI is normal. Could there be a process at some particular level which is not captured by EMG? The answer is yes. And in this particular, somatosensory evoked potentials helped us get to that answer, which showed prolongation of N9 and N13 interval, which improved post-immunotherapy, suggesting a disease process affecting the sensory nerve root, so the small section connecting the spinal cord to the dorsal root ganglia, which cannot be usually easily picked up on electrodiagnostic testing. Interestingly, we've seen other cases, excuse me, which have the sensory nerve root involvement in association with contactin or contactin Caspar-1 complex autoimmunity. Some of these cases have some spillage of disease to the DRG as is expected. And this we've called CIS plus syndrome, or not just chronic immune sensory polyradiculopathy, but chronic immune sensory polyradiculopathy with some nerve involvement as well. So if you are seeing a patient which fits this particular phenotype with just pure sensory nerve root involvement or presenting with a phenotype called as CISP, think about contactin or contactin Caspar-1 complex autoimmunity. Similar presentations of phenotypes have been described by kind of colleagues in Europe as well, but they've not necessarily named it CISP. There's always a concern, is this sort of more DRG process, more sensory root process, or is there some CNS involvement as well? So this is the cheat sheet I usually share with our fellows or residents as I think about autoimmune neuropathies. There are some things which are consistent and common across antibodies. Often tends to be the refractoriness to IVIG, some of the sensory ataxia features, as I showed in both the neurofasciin as well as in the contactin cases, and the demyelinating electrophysiology when present. But there are some things which can help us distinguish whether it's neurofascin, whether it's contactin, and more, we're actively working on a Casper-1 CBA as well, or whether it's Casper-1. For neurofascin, that red flag is tremors or dysarthria, which makes me think more neurofascian autoimmunity. Whereas for contactin, it's CISP, the plus renal involvement, or membranous glomerular nephropathy. So in some of our CIDP cases, think about doing 24-hour urine testing to look for evidence of proteinuria. And then many of the Casper-1 cases also have a sensory predominant presentation, often presenting with pain, along with sort of other features of autoimmune neuropathy. Moving on from sort of this large fiber neuropathies, axonal demyelinating, to some small fiber presentations and some hyperexcitability syndromes, Casper-2 and LGI1, which we've sort of included in our axonal neuropathy panel, are two antibodies that have been described in association with small fiber involvements or pain syndromes. These are not your typical small fiber neuropathy patients presenting to your clinic with slow progressing disease over many, many years. These are patients who have often non-length dependent pattern of small fiber involvement with just abdominal involvement and then spreading to the legs, like you can see in this particular sweat test, or more diffuse involvement with significant dysautonomia, autonomic dysfunction with refractory neuropathic pain, like you can see in this particular case. Some of these patients, in addition to the pain presentations, can have hyperexcitability. This is one of our patients presenting with sort of muscle cramps and fasciculations. Let me see. So here you can clearly see there's something not normal. Even when we stuck a needle in this muscle, there was clear evidence of neuromyotonia. This patient came back positive for Casper-2 antibodies, seems consistent with what we see in ISAC syndrome or with CNS involvement, Morvan syndrome. This other patient who also has peripheral hyperexcitability, but the hyperexcitability is at the level of the muscle. I just included a video to show you the difference in the presentation, where this is more of a rippling phenotype. And this is not what we typically see with Casper-2 autoimmunity, but this patient had a muscle disease called Cabin-4. But sometimes if you have not seen these cases in clinic, it can be difficult to distinguish. So our hope is to potentially test for all of these conditions using specific tests. So if you're seeing a hyperexcitability presentation, you can look for all of these antibodies together. Interestingly, we've encountered recently other antibodies with sort of these hyperexcitability manifestations. This is a relatively recent case seen last month, or actually a couple of months ago, presenting with memory changes, episodic dysarthria and dysphagia. And the episodes of the dysarthria and dysphagia were coming from these very unique tongue movements. You can see that particular presentation, if I see in clinic, I would probably, the first thought would be, is this Whipple's disease presenting with myarrhythmia? But given our neuromuscular interests, we also stuck a needle in the tongue. And what we heard was EMG features suggestive of myochemic discharges, along with that phenomenology which suggests myarrhythmia. So it's a combination of myarrhythmia and myochemia. So far, we've had now 3 cases already with this particular antibody, all of whom are positive for Eglon5. So we talked about ALS-like presentations that suggest both central and peripheral involvement with Eglon5 autoimmunity. That's another unique phenotype with both central and peripheral involvement presenting with hyperexcitability or myochemic discharges in the tongue that we've encountered in these particular patients with Eglon5 autoimmunity. Another set of antibodies that are included or in our panel are ganglioside antibodies. These are specifically useful in certain neuropathy subtypes. The most useful ganglioside antibodies that I feel are most useful are GM1 IgM antibodies and GQ1B antibodies. GM1 IgM specifically looking for MMN in patients presenting with a multifocal asymmetric motor weakness like presentations. IgM tends to have higher specificity for MMN than IgG, and then GQ1B antibody seems to have a very high specificity for GQ1B syndrome, especially the higher titer GQ1B presentations. Some of the other ganglioside antibodies are also useful, especially in management and diagnosis of GBS cases. However, these are not necessarily required or needed in the diagnostic criteria. I always find it helpful to kind of try and understand why these things are called the way they are, GM1, GD1B, GQ1B. And this is the breakdown of sort of nomenclature for various ganglioside antibodies, where G stands for ganglioside and some of these other M and numbers stand for sialic residues or tetrasaccharide chains. So with that, going back to that initial phenotype algorithm, sort of I wanted to give you example of some of these cases to try and kind of connect the dots in terms of if you're on your examination, on your EMG, if you're seeing a sensory neuropathy presentation, these are the list of antibodies such as ANA1, CRIMP5 that we should think about. We're seeing an axonal political neuropathy, as we showed in the case of CRIMP5, but there are other antibodies like MAP1B or PCA2 or amphiphysine that can be associated with that. The ALS-like presentations with those red flags like REM behavioral disorder or history of multifocal involvement or cancer should make you think about antibodies like Iglon-5 or in some cases leucine super-4. And then the demyelinating electrophysiologies of the CIDP-like presentations, neurofasciins, contactin, Casper-1, Casper-1 contactin complex end up being much more useful in terms of investigations. Moving to the lab side, these are some of the techniques that we often utilize for testing of these antibodies associated with neuropathies. Our workhorse is tissue immunofluorescence assay, especially for some of the classic paraneoplastic antibodies. But as time has gone on and we focused on newer antibodies such as neurofascin 155, we've started investigating other assays like live flow-based assays, which have made it to the lab. But whenever we either discover or bring in an antibody discovered by others into the lab, we often investigate it on multiple different platforms before we make a decision on what would be the best way to offer this particular test. And the reason that why that is important is we are dealing with extremely rare diseases. So this is a figure we generated for a recent editorial about a paper which talked about false positivity. And what we wanted to demonstrate here is what we are dealing with is really rare diseases. So here in that 0.5 zone, as we come towards lower prevalence numbers, you can see that even a test which is highly specific, let's say a 90% sensitivity specific test, clearly has much higher false discovery rate. That is the proportion of false positive tests. Not only that, the performance of the test starts mattering even more for these rare diseases. So these are comparisons between a test with 90% sensitivity specificity versus 90% sensitivity and 99% specificity. And you can see there's a much bigger difference for rare diseases compared to not so rare conditions. So it's the onus lies not only on us to generate and utilize highly specific tests, but also on the clinicians who are ordering these tests to select out, identify the subset of cases where you think the antibody actually is going to be positive, which fits with the existing literature about these antibodies before sending these tests instead of in every neuropathy patient. And as I said, neuropathy is very common. So those numbers are going to be very a lot contributing to some of these false positive results. So touching on what things we keep in mind while not only formulating these testing algorithms, but also while interpreting these tests on your side when you get the test results. One of them, which is very useful, is what assay is being utilized. So this is a study from Lyon, where they took patients who were tested for paraneoplastic antibodies and just tested on line blots and showed that more than 80% of patients who were just line blot positive but negative on tissue immunofluorescence assay did not have a paraneoplastic phenotype or a paraneoplastic syndrome. That's 80% is a big number. So that's something which we have seen in our clinic as well. I've seen patients with amphiphysine antibody positivity on a line blot who don't have amphiphysine autoimmunity or paraneoplastic syndrome. So think about if you're seeing a test result which is positive, but the presentation doesn't seem to go along with the test result, could the type of assay being used be contributing to some false positive result? The second thing which we have briefly touched on was what secondary is being utilized for testing. So neurofascin is a perfect example of that, where the patient is just positive for neurofascin 155 IgG, but is negative for neurofascin 55 IgG4. Often those patients don't necessarily have the autoimmune neuropathy phenotype. This is a patient I've shared with Jim Dick, who was positive 155, had a presentation looking like CIDP. We did a nerve biopsy. Also, nerve biopsy showed onion bulbs, something we don't encounter in autoimmune neuropathy. Patient did not respond well to B-cell depleting therapies, which was given the concern for neurofascial autoimmunity, but responded favorably to IVIG. So there have been other cases like this who didn't even have CIDP, had sort of limb-dependent neuropathy from diabetes, had Bell's palsy, who were positive for 155 IgG only without IgG4 positivity. So look at that secondary antibody value, or what type of secondary antibody is being utilized for certain antibodies, such as some of these autoimmune neuropathy things. It's much more evident for, let's say, IgM testing. So neurofascial 155 IgM doesn't seem to have high clinical specificity. Not only we have reported it in one of our papers in neurology, but similar findings have been reported by the UPenn group, showing IgM doesn't seem to have high clinical specificity. And then, similar to the paraneoplastic scenario, even for autoimmune neuropathy biomarkers, assays matter. So the live flow-based assay versus tests like ELISA, Western blots, there is a difference in the performance, not only in terms of identifying true positive cases, but also sort of potentially eliminating false positivity like we're seeing in patients with ALS, which ended up being positive for ELISA. And then for certain antibodies, the titers matter, not for every antibody, but for certain specific antibodies, such as alpha-3 ganglionic receptor antibody, which at lower titers can be associated with diverse phenotypic presentations. But usually levels above 0.4 nanomoles per liter, if the testing is being done by radioimmunoassay, tends to be predictive of autoimmune autonomic ganglionopathy. It's interesting that titers also tend to correlate with CAS scores, or the severity of autoimmune autonomic ganglionopathy. And another antibody which can be really problematic to deal with is MAG. The magic number for MAG is not necessarily just positive or negative, which ends up being around 1500 BTU. The number that we should keep in our mind if the testing is being done through sort of the Buman kit is 10,000, where values above or titers above 10,000 seem to be associated with the DADS phenotype, which is the typical disease we are looking for when we are testing for MAG. And then in our experience, certain antibodies that have been sort of being utilized for antibody autoimmune neuropathy testing may not have the same level of specificity as it was initially projected or reported. One of them being TSH-DS IgM. This is a study done by one of our fellows currently, a colleague and faculty at University of Minnesota, where we reported our experience with seeing these patients in peripheral nerve clinic, and majority of these patients did not have an autoimmune neuropathy. Some of these patients didn't even have a neuropathy. So usually sort of going back and thinking about, are some of the antibodies which we are seeing these patients for, are they truly specific? Are they truly suggestive of an autoimmune disorder? Is also something we should do. The same applies for antibodies such as triational antibody, which did not stand the test of time and currently are not necessarily considered a biomarker for myasthenia gravis or even a paraneoplastic disease process. So as we come towards the end of the talk, some of the take-home points, one of them, again, going back to that algorithm or that table, suggesting think about the phenotypic presentation of the neuropathy before ordering the test. It'll help you order the right kind of test to cover all your bases as far as antibodies are concerned. Also would reduce the chances of false positive test results. There are various antibodies such as CRIM5, which can present with sort of more painful asymmetric polyradicular neuropathy, have clear evidence of a T-cell mediated disease process. These are antibodies which are suggestive of more refractory diseases, often require broader medications such as cyclophosphamide to treat these cases, whereas there are others such as neurofascial autoimmunity or neurofascial 155 IgG4 antibody-associated autoimmune neuropathy, which can resemble CIDP but clearly have red flags such as tremors, dysarthria, pain presentations, enlarged roots, markedly high proteins, younger age of onset, which can all point you towards testing for these antibodies. And then, of course, there's sort of not only small fiber involvements, but also painful hyperexcitability presentations, such as we saw with Casper-2, which can have an autoimmune basis. And then, as we think about antibodies in our patients, it's very important to remember ultimately what we are treating is the patient and not the antibody itself. So if the patient doesn't seem to fit what has been described in literature as far as that antibody is concerned, think about what could be generating or contributing to that test result, and could that be a false positive result, including the assay being utilized, like line blots, ELISAs, Western blots for certain antibodies, or secondaries being utilized, like using IgM instead of IgG or IgG4 for certain antibodies, and then certain antibodies presenting with sort of lower titers like MAG or alpha 3 ganglionic, and then certain antibodies like striational being one example where the antibody just lacks clinical specificity. So potentially making treatment decision based on some of those antibodies is probably not ideal. With that, I would be happy to take questions.
Wonderful. Thank you so much for a really great presentation, Dr. Dubé. So I will let the audience kind of think about some questions. Please feel free to use to put your questions in the Q&A box. But in the meantime, a couple of questions for you. So in the absence of CBA testing for new antibodies, how reliable are ELISA-based testing assays?
Great question. So it varies from one analyte to another. For certain antibodies, such as ganglioside antibodies, that is the way to go, because that's the test which has sort of been investigated across multiple laboratories and shown to be beneficial, especially if we set the right cutoffs. For certain other antibodies, such as neurofascin, as I suggested, doing those validation studies and method comparison studies to show whether ELISA really performs up to the mark is critical. And if it doesn't, then transitioning to some of the CBAs or potentially identifying the labs which can provide those CBAs or live CBAs is probably best way to serve our patients.
Makes sense. Thank you. Another question, for which specific autoimmune peripheral neuropathies are antibody titers kind of helpful in the diagnosis and in management of these conditions?
So as I mentioned, there are a couple which I mentioned during my talk, one of them being MAG, IgM. I've had a lot of patients with MGUS, or associated neuropathies, which come to our clinic because they have low titers of MAG, with this question of whether I have distal acquired demyelinating symmetric neuropathy. And most of the time, the answer ends up being no. So I think that magic number of 10,000 BTU ends up being very useful in trying to narrow down the cases. And even there, I would highly recommend working closely with your neurophysiologists or EMGers, because the DADS phenotype has a very unique electrodiagnostic signature which can help you diagnose the cases. The second one, which is useful, is alpha 3 ganglionic antibody, which can present with dysautonomia or autonomic ganglionopathy. There, again, the number of 0.4 nanomoles per liter ends up being very useful. We are actively doing work on some of these nodopathy antibodies, such as neurofascin, to see if the higher values or higher titers if they can predict relapses or predict progression. But currently, it's not being offered as a titer assay. But hopefully, as we learn more, we'll probably, and we find it clinically relevant and useful, we'll try to include that. Some of the paraneoplastic antibodies like ANA1, CRIM5, there, if the test is being done in a sensitive, specific manner with tissue IFA being utilized, the titers don't make a difference, because those are T-cell mediated diseases, and antibodies are just sort of bystanders or red flags, not causing the disease.
Got it. Thank you. A question from the audience. How do you approach degenerative motor neuron disease versus ALS-like autoimmune diseases beyond, I might get this wrong, beyond IGLON5 clinical clues? Any other clinical clues that you'd look for?
Great question. I think IGLON5 clues are the first and foremost I think about in terms of where I'm concerned for autoimmunity. The second thing which I sort of presented were looking for certain paraneoplastic syndromes. If the patient has history of cancer, if the patient has had a more rapid progression, especially with bibrachial involvement, with bilateral upper extremity involvement, proximal weakness. In those cases, and with or without multifocal CNS involvement, I think about testing for some of those paraneoplastic antibodies as well. But the most common antibody, even though sort of it's relatively rare, but the most important antibody in the ALS-like presentation is IGLON5.
Okay, great. Thank you. Another question, have you ever seen any association between autoimmune neuropathy and hypophysitis, or encephalopathies with anti-GAD65 positivity?
So great question with two separate questions. I've seen hypophysitis, not necessarily in just a garden variety autoimmune neuropathy without a trigger, but we have had quite a few cases with post-checkpoint inhibitors developing hypophysitis as well as ICI-related neuropathies. So that's the only setting that I've sort of seen it commonly. Regarding the GAD autoimmunity, we recently 2 weeks ago, published a study on GAD antibody associated motor neuronopathy. So actually, it connects to the previous question as well, that we have seen a subset of patients presenting with upper motor neuron predominant ALS phenotype, predominantly bulbar involvement, but more sort of a brainstem localization with some distal EMG changes suggesting of fasciculations, again, looking like ALS, but upper motor neuron predominant ALS, which were GAD65 antibody positive. And those two had very high titers. So that's another antibody where titers make a difference. If you're testing by radioimmunoassay in the serum, we're talking about more than 20 nanomoles per liter. By ELISA, we're talking about more than sort of 10,000 IUs. And those patients, some of those patients actually responded well to treatment. So again, cases with ALS-like presentations where actually you were able to make a difference, stop the disease from progressing, and some of those patients were able to kind of get better with immunotherapy initiation. Outside of that, I've not seen GAD65 autoimmunity presented with neuropathies like distal sensory motor involvement. Many of those cases have diabetes at the same time, and that diabetes could be driving the autoimmune process, or they could have a coexisting unrelated to GAD autoimmunity that could be driving the neuropathy process.
Great, thank you. Another question, how often are you seeking tissue samples to compare to antibody testing? And is there any specific clinical presentation that you have a higher suspicion for that you'd need to pursue biopsy samples?
So I think as time goes on, and I don't think our peripheral nerve colleagues will like it, we we have the frequency in our clinical practice of biopsying people for neuropathy has gone down with utility of genetic testing, with utility of antibody testing. However, we still continue to have patients where our suspicion is microvasculitis or non-systemic vasculitis or systemic vasculitis with sort of ANCAs, PAN, polyarteritis nodosa presentations. Those are the patients I often biopsy. Some of the cases I was showing you pathology of were often patients who were investigator evaluated when the antibody testing was not available. So people were trying to figure out by every means possible what the underlying disease process was, including nerve biopsies. So lately, for mostly disease-specific antibodies where I trust the antibody result, I'm not pursuing nerve biopsies. And that said, there are certain situations where you get an antibody positivity, but the phenotype does not fit, but you're not 100% sure. That could be one scenario where nerve biopsy can be useful or can be helpful in kind of coming to the final conclusion whether what you're dealing with is it an autoimmune disease or not.
Great, makes sense. Questions are rolling in. So next one, is there any current utility of serial dosing of serum and CSF antibodies after treatment of autonomic autoimmune neuropathies or gangliopathies for management and treatment decisions?
So I don't usually utilize this in my clinical practice because oftentimes the patient's examination and some of the paraclinical testing we're doing defines the treatment plan. But there might be some utility in alpha-3 ganglionic antibody-associated autoimmune ganglionopathies, where I have seen titers rise as the patient gets worse. So a very interesting example, I had a patient, young patient who became pregnant. So we kind of started to get her off the immunotherapy. But in that particular case, I did follow titers to try and see if I can intervene before the patients get really develops a lot of morbidity from the autoimmune ganglionopathy. And that was one scenario where it was useful. The other scenario where I found it sometimes useful is towards the end of the treatment course, because our goal is to get these patients finally off the treatment, not necessarily keep them on treatment for a long time. Sometimes as we stop the drug and then follow the patient over, let's say, a year later. So in some of these alpha-3 ganglionic cases, I've used the titer along with examination to just reassure myself that we are doing the right thing. This patient doesn't require ongoing treatment.
Thank you. Last question. Is there a specific pattern of demyelination in the antibody positive CIDP, like conduction block or less demyelination signs?
Oh, very interesting question. So if you actually look at the pathology itself, it's very hard to call these truly demyelinating diseases because the disease process is happening at the junction of the myelin sheath and the axon, so at the level of the paranodes. So oftentimes, the typical electrophysiology features with pure demyelination is not what is encountered in these cases. Most of these patients have evidence of both demyelination as well as axonal loss. Also, interestingly, in my experience, many of these patients don't have evidence of temporal dispersion. That is typically the electrophysiological signature that makes us think about CIDP, or evidence of conduction block like we see in MMN, MAD-SAM, or some of the other CIDP presentation. Their electrophysiologies look somewhat similar to what we encounter in Poems disease, where it's pure reduction in velocity, some reduction in amplitude, without a lot of these ancillary findings such as temporal dispersion, conduction block.
Great. And I lied, there was one more question. So are there any plans to perform assays to measure FSGFR3, TSHDS, and plexin antibodies?
So no plans as of now, but we are actively we're very much interested in growing our antibody portfolio, including other clinically relevant antibodies. So we are actively looking at all of these antibodies, specifically Plexin D1, on a research basis to try and see are they as clinically useful as has been published. And if that is the case, we would love to kind of include them in our panels.
Great. Well, thank you again, Dr. Dubé, for an excellent presentation. And thank you, everyone, for participating in today's Future Directions of Laboratory Medicine webinar on peripheral neuropathy. Thank you again for joining us for the webinar today, and have a great rest of your day.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.